Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to our program this morning. I'm joined on my right-hand person here, Dr. Doc Hawk. Dr. Doc Hawk. Wow, that was great. Hawkeye, Dana Hawkinson, Medical Director of Infection Prevention and Control. I am delighted this morning to welcome three really special guests into our studio or on our program, because we really haven't spoken a lot about the effect of COVID on children. And today we have a team of people who are willing and ready to do that. On my left is Rob Lane. Rob is got a number of titles. He's an Executive Vice President and Physician-in-Chief over at Children's Mercy Hospital. I always say he's doing the same job that I do over at Children's, and has been a great partner to us. Angela Myers is a infectious disease physician at Children's Mercy. And we have from KU, Steve Lauer, who is our vice chair of the pediatric, or we have a combined pediatric department between KU and Children's, and Steve Lauer is a vice chair and really helps run things on our campus and a longtime friend. So I just want to welcome all three. This is a really special program, and I think it's really important that we talk about kids. So before we go into that, let's first hit Dana. Talk to us a little bit. How are the numbers looking today?
Hi. Numbers are good today. 16 today in the hospital, 5 in the ICU, and 3 on ventilators. So our numbers continue to stay somewhat stable. No surges, no spikes yet, and that's a very good thing. If we can keep the numbers lower and lower and eventually get to 0, that would be a great thing. But as low as we can, that's what we're shooting for.
We've been kind of bumping along at this same level now for a while, and I would say in talking to North Kansas City and St. Luke's and some of our other hospitals that are on our CMO call, Olathe, Shawnee Mission, Liberty, Lawrence Memorial, everybody is kind of staying at the same level. It's a little higher than it was, I would say, 2 weeks ago, but it's just pretty flat, so that's a good thing. Rob,
yes.
How are things at Children's? And tell us a little bit about some of the things that you all are encountering with kids, and as a pediatric hospital, some of the issues that you faced.
We are in the process of our Getting Back to Getting Better program. And so this was something I've been really proud of. We started this process essentially when everything started to shut down. So it's really been a credit to multiple folks that have been involved in daily conversations of when it was time to ramp up. How do we do it in a way that is going to be safe, that's going to provide high-value care, as well as recognize all the other things that go on in terms of the issues surrounding a pandemic. I want to give credit to multiple people who've been involved, Dr. Watts, Dr. Myers, and our COO, Jody Coombs. And this has been a carefully planned process. We're presently in wave 2. We're going in sort of 2-week increments, and we've seen people come back, and it's sort of been like a 3-dimensional Jenga in terms of trying to make sure we get people back to make sure kids get the care they need, but at the same time maintain social distancing, make sure there's universal masking. The other thing that we've done that I've been very proud of is we've really ramped up our telemedicine program, and we're still seeing over 70% of our ambulatory visits via telemedicine.
Yeah, that's a big deal, and I know we had to do the same thing. We've started to shift. We're now probably more about 2/3 in person, 1/3 telemedicine.
Okay.
But that's come with a lot of effort.
Sure.
But I think everybody's going to. We're all trying to figure that equation out. I don't know where we'll land. I think we'll always do a lot of telemedicine. I think that's been a great thing. And if there's any politicos listening to the program, I do want to put an ad out. Don't cut funding for telemedicine. This is the best thing that's probably come out of the pandemic, outside of people working better together, is this telemedicine thing. And it's been revolutionary, and I think it opens up access all across countries and in places where there aren't as many physicians, especially rural and inner city areas. I think telemedicine is just so important to the future of healthcare in the United States. So don't cut funding. Keep it open.
I couldn't agree more. One of the things that has surprised us is that we were concerned about how families were going to react to telemedicine. And what we found is that our engagement scores have actually increased significantly, essentially all across the board, with the telemedicine experience. So we've really been delighted with it.
We've seen the same thing. Isn't that funny? People really do like it. And you get to see patients in their home. And I think there's a story there that will be told over time. I think it's really important. I think folks are more comfortable in home and more willing to share about their stories. At least that's been my experience. But I've done a bunch of telemedicine clinics, and I kind of enjoy it.
I think that's spot on.
Yeah, it has. I can't do a very good lung exam across the screen. I said, just cough for me. Let me hear you cough. And sometimes that works, sometimes not so well. All right, Angela Myers, and you're an infectious disease physician at Children's. This has got to have kept you up at night and busy and trying to figure out which way is left and which way is right.
And following the data that comes out, daily in the literature. Some things have been, published ahead of time, even prior to peer review. And so a lot of what we've been doing in my division is really looking at that literature, taking a hard look at it, looking for the validity of it, but then also trying to implement the lessons learned that other folks around our country, but also around the world, have learned throughout this pandemic.
Yeah, and I think that's really true. What's been the biggest challenge for you at Children's? And tell us a little bit about some of that Kawasaki-like things that you guys may be seeing.
Sure. So MIS-C, or Multi System Inflammatory Syndrome of children, is a definite challenge that we have seen kind of later in the course of this pandemic. And, it's associated with...
Oops.
We want her feedback. She was saying something important.
Yeah.
Well, we try and do that. I'm going to turn to Steve Lauer for just a moment. We're going to pivot. Steve, here at KU, large general pediatrics population. You guys have had to change how things go in clinic, and I think, like Rob, experience a lot of telemedicine.
Yeah, absolutely. When we got the telemedicine program going, along with everybody else at KU, it really was a positive, we think, for many of our patients. Like you mentioned, they're able to be in their homes. They don't have to get here. It's a much more natural environment for them to see us. And so we'll be continuing with that in many of the visits going forward, especially around our follow-up visits, mental health visits, that kind of thing. We still haven't figured out how to do a well child visit and on telehealth, and so that's the one we're really focusing on, getting our patients back in here, convincing them it's safe. We've changed a lot of the workflows in clinics so that they don't spend a lot of time in the waiting rooms. They're in their rooms seeing their provider, but we really want them back in, especially around the concerns around vaccination rates. Making sure they keep up all the normal vaccinations and protect their kids from the vaccine preventable diseases that we don't want to see come back as we fight this COVID pandemic.
And Steve, what's different about a well child visit? You see you can't do that. Why is that?
Well, there's some of it's, I think, just with pediatricians, we like to see those patients, see how they're interacting, and maybe you can get used to doing some of that on telehealth. There's a lot of screening, developmental screening that goes on. Some of it with the older kids, some private conversations with the adolescents that can be pretty challenging in the telehealth environment. And then, about half of the well child visits have vaccines with them, and so that's really hard to do. It's up there with the lung exam. Can't really do the vaccines over telehealth.
At least have them cough into the microphone. I don't think you can get a vaccine through a microphone.
That's challenging.
How are you all thinking about that at Children's? It's got to be a topic of pretty big concern.
It is a topic of big concern, and that's why the whole push for the getting back to getting better. We want people to come in, and we have bent over backwards. Again, it's been months, just like I'm sure you have, in terms of trying to provide the safest environment possible. So when we did our clinics and we tried to arrange them, we made sure that we were understanding the geography of them. So again, that we could maintain social distancing. We've been very thoughtful in terms of how people approach the hospital itself, so that we don't have long lines either in our front area or in the waiting rooms.
Yeah, that's got to be a big thing. That whole re-engineering, and that's part of why we closed down the clinics, just to, well, first of all, protect or get our PPE supplies built up, but then to re-engineer our entire environment. So I just have one quick comment. I want to welcome Chris to our program, a new interpreter for us. I think you and Rob coordinated today. You guys are both dressed in black. I don't know about that. Maybe
I'm just grateful I got the memo.
Are you going to start breaking out in Johnny Cash one of you anytime here now? That's right. Here we go. I think we have Angela back on now, and you were talking a moment ago about some big term I think you use, multi-system inflammatory thing of kids or whatever. Talk to us more about that. Explain to our audience what that is and what does it mean and what's going on with COVID-19 in children like that.
Sure. So Multi System Inflammatory Syndrome in children is an inflammatory response that appears to happen after having COVID-19 infection, in fact, a couple of weeks to 4 weeks after having infection. And what it looks like is fever with evidence of inflammation on blood tests, along with organ involvement. And that could be the heart, it could be the kidneys, it could be your blood counts or your GI tract or your skin or even your neurological system. And there's kind of a combination of things that we look at, including laboratory values and physical exam findings, to kind of determine if a patient looks like they might meet these criteria. There is overlap with Kawasaki disease, and it's probably somewhat of a spectrum. So we've known for years and years that Kawasaki disease is an inflammatory response to something, even though we don't exactly know what that something is. And it appears that the similar treatments that we use for Kawasaki disease also help patients with MIS-C.
So, people may have heard me say on this program, well, kids don't get as sick as adults, but that may not always be true. Talk to us a little bit about how are children in general doing with this? Is it still, we've been saying that it's often an asymptomatic process in kids. Talk to us a little bit about what does SARS-CoV-2 mean for children, and what's the biggest threat?
Kids generally do not get as sick as adults. That is true. Most children who develop COVID-19 do have some symptoms, and they may be very mild and so not really brought to medical attention. However, there are a rare or a few children who will develop more severe symptoms and have more severe SARS-CoV-2 infection initially with the infection. And then there's also this rare entity of MIS-C where they may have this inflammatory response after infection. Again, even though the numbers have looked high coming out of some places like New York when they've talked about more than 100 cases or 150 cases, but if you look at that on a population basis and the number of people being infected, it actually is quite a low proportion of children that have this inflammatory response.
It's more fun, though, to have a big headline of 150 kids with some new weird syndrome that we don't understand. Not that was a very small percentage overall. Steve, do you guys get into discussions in the clinic when you see patients about children being asymptomatic carriers and what it can mean for the adults in the household?
Yes, we do. Justifiably, parents tend to come into clinic very worried about how their child is going to react to this infection, if that's what they have, or how to protect them. And frankly, most of the time, we're at least as worried about the parents or the grandparents at home or around these children. So we try and talk about that a lot, protecting that child and making sure that they're doing well, but understanding that, just like Dr. Meyer said, because many aren't very sick or may even be asymptomatic, that they may pose a risk to people at home or people within the extended family. So getting parents to think about the social distancing aspect of this, even within their own families, and protecting everybody else who they may come into contact with.
Rob, I'm sitting here thinking about this whole conversation for a minute, and the fact that you all were still doing more telemedicine, I was struck by. Then I started thinking about, well, actually that makes total sense, because you don't want a lot of people traveling through clinics. Moms can't just leave kids, or dads can't leave all the kids at home. And how do you do that? You can't bring all the kids into the clinic visit with them. That had to be a real challenge, and still an ongoing challenge for pediatric hospitals.
That still is a challenge, and it's something that trying to balance what the family's needs are relative to trying to keep everybody safe, including the other adults in the room as well as the caretakers. I think there's another thing that we need to consider also in terms of the impact on children, is that this has been a unique period, at least in my lifetime, in terms of people not being able to go to school, have the positives of outdoor activities and athletics, some of the socialization that occurs on. There's only so many kids' programs on Netflix. And so that impact just on sort of the mental health of our children, and this whole experience I think could have implications for the next decade.
Yeah, isn't that is so true. We forget because it doesn't. Well, they're kids, but really, man, what a big impact! I know I talked to a couple of moms recently that were really worried about their child, and they're teenagers because of social isolation,
right,
and an increased concern about mental health with kids. Any thoughts from any of you all about that?
No, I think Dr. Lang makes a great point. This is going to be a huge issue going forward. We know that children respond poorly to persistent levels of stress, and we get to that toxic stress level where they don't get any relief. It builds up into those adverse childhood events, and we know that over time, those can have long-term, decades-long effects on both mental and physical health. So I think as we move from trying to contain COVID to more kind of a living with it, that this is one of the things we're really going to have to look at and address the stress that this is causing persistently in families and for kids.
So what can parents do about that, Rob? What are some ideas for how parents should help protect their children or cope with that? Because that sounds a whole lot like PTSD in the making.
I think there needs to be some judgment involved, but still, what grandmother taught us, get outside and play.
Yeah.
Now you may have to play with social isolation. It may need more interaction and less Netflix or YouTube TV. But getting up and around, trying to socialize as much as possible, trying to interact, but maintaining all those other concerns. I think the other thing that struck me, I would absolutely acknowledge that this struck me in terms of healthcare workers, but that's still significant in our community with the 13,000 at KU and 8,000 at Children's. But I think it affects everybody on further reflection, is that everybody has a certain level of stress at work, and hopefully for many of us, when you go home, that stress goes away. And one of the things that I think COVID has impacted all of us on is that there's stress and anxiety anywhere you go. Because it is a worry when you're at home. It is a worry about because you're disrupting your normal activities. So again, this is going to be a challenge that we've never traveled this journey before.
It is a hard one. Well, let's see if there are questions from media that are listening to the program this morning. Jill, I bet you have a few that are lining up for us.
We do. In fact, we had people asking when you were going to be on in Children's Mercy and the
That means you may have to make a return visit, man. if you're popular, you have to come back.
Let's start. I'll start with the smallest. Questions around infants, newborns, the whole thing about taking them out. How do you keep them safe? Do you let people come in? Can I put a mask on an infant?
Angela, what do you think? How do we protect the newborns who have just come home, and then as you answer that, also answer what happens with a positive mom as far as transmission to children?
Sure. So that's a great question. It's not a good idea to put a mask on an infant. In fact, the CDC doesn't recommend putting a mask on a child under the age of 2. I would also extend that to say that it needs to be developmentally appropriate. So children who have developmental delays may not be able to wear masks as well. So, it's always important to protect your newborn infant, even in times that isn't during COVID. There's a number of infections that newborns can get, and if a newborn or in the first couple months of life develops a fever, then we do a pretty extensive infectious diseases evaluation in that setting. So it's always a good idea to limit who is seeing the child, making sure they're healthy, making sure they wash their hands, before you allow anybody to see your child. And keeping that baby at home for the first few weeks of life is actually a really good idea, even in non-COVID times. In terms of moms who are positive for coronavirus infection at the time of delivery, there really has not been shown that there is much in the way of transmission from mom to baby in terms of from the pregnancy itself. Certainly there is some risk after the baby is born, if mom is actively shedding virus and is actively infective. However, there's really good recommendations in place around how to kind of mitigate that by keeping baby away from mom for a little bit of time, having mom wear a mask, having mom wash hands, and things of that nature whenever she cares for the baby. And we also test newborn babies of moms who are positive to ensure that the baby hasn't been infected.
Yeah,
I would also like to mention one other thing. There's actually some really good new data that has come out that child-to-child transmission is really, really minimal, and child-to-adult transmission is really, really minimal. So as we have more data out there and we understand a little bit more about how the virus is transmitted, I think that provides us a sense of relief that children are not spreading this infection to each other and generally not spreading it to adults very often, which is different than other respiratory viruses like influenza.
Angela, you got to explain it to me, because we've always thought, man, the kids with the vectors, watch out, and we're worried about schools and things of that nature. But because that statement has a lot of broad implications. So, talk to us a little bit about why you think that is and what's going on. And then we'll turn to Dana too from the adult side and say, gosh, so talk to us about what's up.
Absolutely. So there's a new paper published in the Journal of Pediatrics recently that looked at, they did contact tracing of household contacts of 40 children who were diagnosed with SARS-CoV-2 between March and April. This study took place in Switzerland, and when they did the contact tracing, what they were able to do was determine who developed symptoms first in the household, and in only 3 cases, or 8% of the time, did the child develop symptoms before the adult in the household, which really leads you to believe that the child was likely the index case in that scenario. But in the other scenarios, they really weren't. They were getting infected from an adult. This adds to other data that has come out of France and come out of Australia, looking at school-age children all the way from elementary school through high school, and looking at secondary infections from both students who were infected and then also teachers and staff that were infected, and the really extremely low rate of transmission that happened from that standpoint as well. So I think that this story continues to evolve as we get more and more data, and I think we need to continue to look toward our partners around the world as more literature comes out. But I think that those three kind of examples really provide some reassurance that child-to-child transmission really is not very significant for this virus, and neither is child to adult.
Or whether that may be true? I don't have any ideas either. I would have said they were going to be vectors, but obviously I'm wrong. Again, which comes as no surprise to my wife and family.
All right. What about having, how do you screen for a babysitter?
Great question. Okay, how do you screen for a babysitter? Steve, what would you tell people?
Well, just like the rules around where you should have your, the exposure you have with your kids for, to other people, I think those rules probably haven't changed. Who's that? What's that babysitter's experience? Where have they been? What have they been doing lately? All the questions I think you would ask normally, and then just I think a sense of how that potential babysitter views the seriousness of this. I mean, there's certainly still some variation in that. So are they taking it seriously and understand the risks that they bring by coming into your house, and making sure that they're willing to follow all the rules that you want them to around keeping your children and the rest of your household safe?
Yeah, it feels like, Rob, this is a question of risk tolerance once again.
Yes.
And how do you handle that, and what's the equation for it?
There is no formal equation, nor is there a simple answer. It's really going to end up being a judgment call. I absolutely agree with everything that Steve said. I think I would include asking the questions that we all ask in our screening, asking about recent temperatures, coughs, symptoms, and exposures and trips. But it will become a judgment call in the long run.
Yeah, that sounds so familiar to me about what's in a bubble, Dana, what's outside the bubble. We've talked about that extensively.
Absolutely.
So are you? I'm still can't quite get past this idea that kids aren't spreading it, and obviously believe Angela. So any other ideas from your standpoint at why that's true?
Yeah,
other than I'm wrong again.
And Steve and I were talking before all this. I think it's certainly because we've gone on dogma of other respiratory viruses. We understand that children can spread. We understand that gastrointestinal bugs can spread, diarrhea issues in the daycares and in schools. We don't exactly know why this is interesting information. The studies that were cited were based on indirect evidence of no secondary contacts, and we know that other studies, adult studies, for instance, about reinfection, and if you're infected with it once, can you get reinfected, like in the South Korea experience? They based a lot of those studies on the indirect evidence of no household contacts getting infected as well. So we have other references that have similar kind of findings. I don't know if it's just because maybe in general they don't get as ill, so maybe their viral loads are not as high. I don't know on a child about their coughing and breathing and how far their droplets go, things of that nature. We certainly know they probably cannot physical distance as well as adults, and probably don't have the good hand hygiene and inability to stop touching their face as much as adults either. So it's really interesting findings, but I think it's a good thing. I think throughout this course we have always been grateful that children are not affected in the proportions that adults are. The ill children are exceedingly rare compared to adults, and then of course the inflammatory process is a horrible disease, but that's an exceedingly low percent of the population, and so we're grateful for that. Hopefully we continue to learn more about the pediatric experience here.
I'm just so surprised by all that. Not that that changes anything, but rule number 6 in the ICU, you've heard me say it before, you've got to know what you don't know. And man, there's so much we don't know. And don't worry, to the listening audience, somewhere before the end of this program on COVID-19, we will get to all 10 of my IC rules. So there's still a couple good ones out there.
Okay, similar question. Pacts with parents. If I'm going to increase my social bubble, do I need to make a pact with the other parents about what we both agree our households are going to do?
Wow, that's a hard one, Rob. Is that part of the infection control policy at Children's Mercy? Are y'all doing pacts with parents?
We are, I guess you could say we are, because we're trusting people in the screening process in terms of answering the questions. Again, I think that comes to your judgment call. That seems to be a very reasonable thing to do, to talk about with parents and families that you want to increase your social bubble with. What are the ways to try to minimize the risk overall? Because it really is about how you want to take care of each other. What Dr. Myers will continue to teach me is that a key to this will continue to be, hand washing, social distancing, and being aware of your symptoms. But that could be a very reasonable approach. It will come down to a judgment. There's going to be no hard, fast rule.
Steve, have you done any of the packs, or how have you informed your patients in the general clinic?
Well, I think we have to start from, we know we can't continue to ask people to do what we've done in March, April, and May. That's just not going to work. So I think it is that thoughtful consideration of how you do that slowly and methodically in a way that you can start to have some of those important social interactions, do a bit more, take some of that stress off of your family while physically protecting them. So yeah, it's going to be that case by case, talking with your neighbors or your family members to see how you can as safely as you can expand that bubble. Again, realizing we can't keep doing what we've been doing, that there's downsides and harm that comes from that as well. So just being thoughtful and go slow.
Yeah, it is. So it's such a funny world out there.
What about having a housekeeper come into my house to clean, and if I have children? And some are asking about grandma and grandpa. Is it okay to have a house cleaner go in there? Do I have to stay away from my house?
Angela, you start with this one. I'm picking on everybody. I'm picking on you this time. Yeah. Good luck with this question, by the way.
With the house cleaner? Sure. So, I think you would interview your house cleaner like you would anybody else who you're going to invite into your home to work, such as a nanny or a babysitter like we already spoke about. So you want to ensure that they're healthy, and by asking the questions that you would normally ask about respiratory symptoms or other symptoms related to COVID or fevers. And you want to ensure that they have good cleaning practices within the company they work for, if they're an individual, business owner too. So, I think it's okay. I think you need to make that decision for yourself and how comfortable you feel with how the person is going to operate within your household, and do the work that, they want to do and that you would like to have done.
Dana, the quick story here. Yesterday, my wife and I, we downsized and we moved into this condominium, and she has a piano that's kind of a family thing, and we moved it. I won this discussion finally. We got moved down to a different room, which is a rare victory for Steve.
Right.
It did take over the my own one room I own, or I could to do some decoration in. But having said that, the moving company came there to move the piano, and nobody wore a mask, and we had to try and find something, scurry around, and my wife did to get masks. Why do we think that companies are not thinking about wearing masks when their people are out in public in other people's homes?
Yeah, I don't know. It's such a simple thing to do. I think with the question about the maid or movers, movers are going to be moving in and out. Obviously, they're going to be lifting heavy things, but I don't think they need to keep the mask on that long. Maybe once they get outside, catch their breath. Certainly in the household, it's probably important. You can always pre-screen your house cleaner, the day before. Do you know anybody who's had COVID? Are you having any symptoms? I think it's important to ask them to wear a mask, obviously, especially, and if you can leave the premises, a lot of people have it done while they're at work. That's another important thing to do. And those are things that you can do, and I think really cut down on your risk by doing those.
Okay.
Speech therapy.
Speech therapy. Can we go back to it? What do you think, Rob? I mean, that's a big deal for kids.
Again, I would think so. I suspect any reputable speech therapist is doing the same things that we all are doing in terms of healthcare. Trying to maintain the social distancing, working on masking appropriately.
But can you do that? Can you mask and do speech therapy? I think that's part of their question too, because they have to get close. They need to see your mouth.
Yeah, how's it moving? What's going on? But that's one of those really hard ones. Adults are kids. I don't know, Steve. You're shaking your head. I watch you shaking your head, and I can pick on you for that.
Yeah, I mean, I think it's we're all going to have to be adjusting how we work and how we think about it. I mean, we have to do it in the General Peds clinic and how we're spacing. I don't know speech therapy that well. I would wonder, can some of that be done with cameras and telehealth? Potentially, I think we're all going to have to think about how we come up with hybrids of our old workflows to address the new reality.
I think that's probably true, and it's certainly true in so many other areas of medicine where we have had to make those adjustments. And I do a lot of cystic fibrosis and see some transplant patients, and the answer has always been, I'm going to see you on telehealth initially. We got things feeling like we have a safe plan, and now we bring people back in a clinical environment. Most patients like being able to have that direct interpersonal, I think, connection with physicians, but some of them are sick and we're nervous about them, or they live far away, or they have trouble getting here. Telemedicine's right there. So I think long run it'll be a 2/3, 1/3 kind of thing. So
I think.
Go ahead, Rob.
I do think there is one advantage with healthcare workers and institutions in that we've all been screened every single day that we come in. So there is that longitudinal. We've not been, and that's essentially been documented. I know at Mercy we are all screened. Our screening is documented. Our temperatures are documented.
Yep.
And so, at least in terms of the healthcare institutions, they're as safe as I think you can have it.
I think that's exactly right. I think healthcare is actually, if you took the whole thing and looked at all infectious disease, I actually think healthcare is safer today than it was before COVID, even with COVID out there. I think your risks are less because we do such a better job, Dana, of infection control than we did before. And we'd like to say we did it well before, but I got to tell you, we do it much better now.
Absolutely. We have. Finally, as we get through these 6 or 8 to 10 weeks, like I said, we were preparing for emerging infectious diseases for years. As our COVID experience has evolved, our infection prevention practices and systems have evolved as well. And so I think we continue to evolve those, but I think they are much better now, obviously, than they were 6, 8, 10 weeks ago.
I think that's even considering the pandemic and considering COVID-19. I still say patients are safer coming to clinic than they were before. Angela, how do you feel about pediatrics? Do you think that's true or untrue with kids?
I think it's absolutely true. I think we've learned a lot from each other and have implemented really good infection control practices, including, more extensive cleaning of high-touch surfaces. As Rob Lane mentioned, we are screened every day we come to work, including a temperature check. All of the healthcare providers are wearing masks when seeing patients. The patients and the families are also wearing masks, provided the patient is of age and also able to. I think this has been an eye-opening experience for everybody involved.
It is, so it's such a big deal.
All right, what's the youngest COVID patient that you've had? And do children with underlying heart conditions, cystic fibrosis?
Are they more at risk? You bet. Rob, what's the youngest?
I'll turn that to Stacy.
All right.
To Angie.
Man, I
So the youngest that we've had within our hospital system is a neonate within the first couple of months of life. And that patient did very, very well, had minimal symptoms, and was discharged home. We've had relatively few children that have been admitted to the hospital with infection from coronavirus.
Kids with
I think there was another part to that question.
Other diseases, be it heart disease or lung disease, cystic fibrosis or cancer, are they more at risk? Because we sure know that's true in the adult population. How about in the pediatric population?
Yeah, so it appears that children with cancer are not more at risk. There's some early data that came out of Italy. We are following the Infectious Diseases Society of America guidelines, though, and actually testing our immunocompromised population when they come into the hospital for chemo, or they come in or they get biologics or initiation of other immune suppressive therapy. However, there's some newer, I think, data that just came out that I came across my computer around heart transplants and being at increased risk for severe disease, which makes sense. So I think there's going to be more to come on that. It appears that cancer is not a big risk in children in terms of more severe COVID-19 infection, but I think we still need to look at other forms of immune suppression and other underlying comorbidities that actually may play a bigger role.
Regarding the study, could it be that because they stayed at home, that was why they had better results? And is 40 a good sample? 40
All right,
people?
so there you go.
Was it 40
Angela,
people?
I think this is what we're following up on the study that said children aren't as communicable as we thought. Talk to us a little bit more about any reasons why that could be true. And I know we're asking you to speculate with that, and infectious disease doctors hate speculation, but we're asking you to do that anyway because this is media, and by gosh, we're going to speculate a little bit.
Yeah, of course. So 40 is not a huge number. That's true. It's adding to it's. The data is additive over time, and the data out of Australia was it only had 18 total people, 9 students, 9 staff that were infected, but they exposed 735 other students and 128 other staff, and there were only a couple of infections that came from that. So those numbers are a little bit larger, and I think a little add to the data and are helpful. And so I just want to put that out there. There's a good commentary that goes along with that paper that speculates a little bit around children having more mild symptoms and thus not coughing, and so thus not, having these respiratory droplets that are coming out of their mouths and noses to expose other people. This is similar, if you think about it, to tuberculosis. So adults with TB are oftentimes very infectious, and children are generally not, when they're young, very infectious with tuberculosis. So it may be more similar to something like TB than something like influenza in terms of communicability.
We've talked before on this program, as pulmonologists at least, that how respirable is respirable. So how easy is it to spread in secretions? And it's not just that you cough. There's so much that goes into whether or not a virus or a bacteria in your secretions can actually cause disease in someone else. It's not just that you cough it out. It depends on what's around it, how healthy that particular bug is, how your body's responded to it. Is the virus damaged a little bit from things your body has done with inflammatory mediators, etc.? So this is not a simple question. I'm sure that Watson or that Sherlock would say it's elemental, dear Watson, but I'm not sure it is elemental in this case. I think it's actually pretty darn complicated.
What is the risk of older children that are going to the protests to bringing COVID home to younger children?
Yeah, that's a good one. All right, Angela, I'm sure that's right up your alley.
Yeah, I think there is a risk. There's definitely risk of asymptomatic and pre-symptomatic colonization and thus shedding, like I said, right before you develop symptoms. And folks, it appears, are out at these protests not really able to socially distance. So they're pretty close together, walking through the streets. Some have on masks, some do not have on masks. I have a feeling that there's not a lot of good hand hygiene available throughout kind of the whole protest area. I think it is a risk, and I think that's something to talk with your older teens and young adult children about, and really weigh those risks and benefits. Kind of determining if it's a good idea to participate in that or not.
Rob and Steve, we spoke a moment ago about the PTSD from the coronavirus, but clearly the protests and the images that we see on the screen around concerns around racism, that has to be taking a toll. I just think for a kid right now,
Sure,
you're isolated, and now you see this other thing going on. I mean, that's got to be tough.
it has to be. So, again, I don't think there's any prescriptive answer other than talk to your children about it. Ask them how they are feeling. Give them the opportunity to talk and express their fears. Let them know what you think. It should be an active and open dialogue. They should be aware. I think there's more fear that comes with hiding these issues than there is with an open, transparent conversation.
Yeah, I think that open, transparent part is so important, Steve. And you must be having this question pop up in your practice.
Right. I agree. We know from previous studies that stressful times, whatever that stress is, for children and adolescents, the presence of that consistent, caring adult who's asking them questions, checking in on how they're doing, really trying to be involved in their life is the difference between dealing successfully with those high levels of stress and having that stress turn into more of the toxic stress, the post-traumatic stress syndrome kind of approach. So the advice to parents is more engagement with your kids, listening to them, asking them questions, and seeing how they're doing. And if we have a role in the healthcare world to help you with that, please let us know.
Well, just to say, one of the things we've tried to do on this program is to be honest and have a good conversation and a real conversation about events and not try to speak with hyperbole. But I do think next week we'll probably try to explore some of the impacts of what exclusion means. And we're not going to be political, but we do want to take on issues that are important, because there is no question that coronavirus and now protests and the things we're seeing in our streets, wow, this is a time that we need to explore the mental health aspects, the health aspects of what we're seeing.
We have a lot of questions from the study that they're wanting clarification now. What are the ages of the children? Do I need to have them wash their hands?
Yeah.
Do they have to wear a mask?
Yeah, I was listening to that study, and I was thinking, wow. And that's the kind of information we want to put out from this program, because we want people to understand and know what we're seeing. But it does raise a lot of questions about youth sports and schools and daycare, and let's go to the lake and hang out with Johnny, and college campus reopenings, Dana, as we start thinking about that, because we're working with KU to think, how is that going to work? And so lots of questions about that. So, Angela, anything else you want to give us? Are there other studies that you're aware of that are being poised to come out, or other information that may be available soon?
I don't know anything that's poised to come out, but my hope is that this will continue to come out. More information will continue to come out, and this will evolve. I think, of course, children should still be washing their hands, so should adults. I mean, there's many other infections that we can get besides coronavirus, and proper hand washing has always been and will always be a very important part of our lives. In terms of masking, for now, I think we should follow the CDC recommendations, and we should continue to be masking out in public and when we can't be, really well socially distanced from each other, or we're in a group of people. But I think this data that's coming out now, and that hopefully more data will be coming out over the next month or two, will help inform what should happen with schools in the upcoming school year.
And the age range you mentioned was from very young children up through high school, I think. Is that right?
In the Australian data, it was elementary school through high school.
And Dana, I wonder when people become adults. My wife would say that, well, many would say I've not crossed that threshold yet.
Right. Yeah, I don't know either. In this day and age, maybe up to 30, who knows? No, typically we consider pediatrics till about 18. And as adult infectious disease, we will occasionally see patients that are younger, 16, 17, if needed. But certainly, I think for the most, in general, if you're hearing about pediatrics, it's obviously going to be newborn through probably about 18. And I don't know if Steve has any other comments about that.
What do you think, Steve?
Yeah, I mean, we stretch that a little bit out through college, so up to 21. But 18 to 21 is the traditional one. But again, nothing dramatic physiologically happens on your 18th or 21st birthday. It's a continuum, and so we're going to have to apply the rules across the board. The rules about fighting a pandemic don't change. Wash your hands, wear a mask, social distancing. That whether it's mildly infectious or very infectious, it's still an infectious disease, and the same rules apply.
So I just want to tell Steve, you and Angela a little bit. I didn't hear you talk about ages up to 60 for kids, and I just somehow I was hoping I would hear a little broader age range for some of us.
You're a child at heart.
Well, we're just doing chronologic age. We're just doing chronologic age, not emotional age, Steve. So.
Maybe that makes a difference. Yeah. Okay, last question, I think.
We have people that are writing in about day camps and sports where the adults are wearing the mask, but the kids are not. Does that mean the adults are at higher risk given they are around the children for longer periods of time daily? Can you help reconcile that?
Okay, Angela, here you go. I think we're going to have you and Rob back pretty soon. Because I think we raised a whole bunch of questions. So go. You've guaranteed us a return.
So again, it appears based on some of the newer data that has come out that children really aren't transmitting to adults. Hopefully, if a kid is participating in a day camp or a sport, they're out on the field with their peers, their other children, and the parents are far away on the sidelines wearing their masks, so that the contact of other people's children to those adults should be minimal at best. And so I wouldn't really be super concerned about the adult exposure in that situation, provided the adult is doing all the things they should be doing, wearing their mask, washing their hands, not touching a lot of different things, not messing with the mask on their face, because the more you touch your face, the more contamination you get there.
Yeah. Other thoughts, Steve, from anything? Any other final comments for today?
I think the upcoming ones about sports and return to school are just going to have to be handled very cautiously. As Angela has noted, we're learning more every day, and these things will continue to evolve, but it's still a dangerous situation, and the abundance of caution approach, I think, will serve people well as we head into the summer and then into the fall.
Dana, final thoughts today?
Yeah, I think all these comments were good, and I echo exactly what Steve said before. We are dealing with this pandemic, but we can't forget that general health of our children are needed as well. Vaccinations are very important. Yep. In the Democratic Republic of the Congo, they're dealing with Ebola, but also measles. So there are still things that we can easily prevent in the time of COVID that we need to prevent, because we don't want to be dealing with multiple wars on multiple fronts. So vaccination is very important for overall health, and especially as we move into the fall with influenza vaccine as well.
Rob?
Comes down to people using their judgment. We talked about the social pacts. We talked about interacting maybe not with as wide a social group that you may have had, but maybe a smaller, ones that you know well and have trusted and have been talking to on a consistent basis during this whole experience. That may be worth the experience, because people do need socialization. Kids do need socialization. And so it's going to take some thoughtfulness. It's going to take one step at a time. And trying to balance the risk versus the benefits of the socialization and just having fun. There's always value to just having fun.
I want to say a special thank you to Rob and Angela for being here today. I do think you all have earned a return engagement. And I really want to just call out the special relationship between KU and Children's, which has been fostered over the last few years. This has been such a great thing. And if Mike Gartman's out there listening, the former chair of pediatrics at Children's and a real partner in helping us put this together, has been just a brilliant thing. We've talked a lot about what we don't know, and I think we've talked about what we do know and learning every day. You do have to know what you don't know, and then you have to decide what your risk tolerance is. the best thing you can do is try and stay safe. Keep your family safe, keep your children safe, keep the conversations going. We'll be here next week to do just that. We'll be here tomorrow when we talk with all things testing. KDHE Secretary Lee Norman returns, along with Rachel Leisman from our lab and Dana, and we'll be talking about antibody testing and what that may actually mean. So until then, stay safe out there.